Hello, my name is Thiago Reis. I am a fellow at the International Renal Research Institute of Vicenza, and today we're going to discuss about interpretation of clinical trials based on the knowledge acquired in the course provided by the Harvard School of Public Health called Principles and Practice of Clinical Research, PPCR. We've chosen to discuss today a trial called the liver trial, just as a pretest to explore the strategies involved in this trial. I'll share my screen. One second, put it there. Okay, so this is the course, as I said, PPCR, provided by Harvard School of Public Health. These are my disclosures. And we will cover the following topics: sampling, research question hypothesis, and the F.I.N.E.R acronym, design and the PICOT acronym, randomization, sample size calculation, primary confirmatory or secondary exploratory outcomes, and subgroup analysis. So this is the protocol from the trial that was published in 2021, entitled Dapa Glyphosate in Heart Failure with Preserved and Mildly Reduced Ejection Fraction, the liver trial. First, about sampling. Ideally, we should test our interventions in the whole population, and this will bring us the real result of that intervention. So we have here the whole population. We have the target population in the case of our study, patients with heart failure. And then we have a subset of patients that can be studied for a vast reason, different reasons. And then we have our final sample. So, you know, that you see that we shrink the number of patients evaluated. There are different ways of sampling. One of this is in clusters. So you go in centers, in referral centers, to allocate and enroll patients. In this example here in the north of Italy, we could go and get patients from the center of Arzignano, the center of Valdagno, and Vicenza. But there is a limitation in this sampling method, because we cannot say that this sample represents whole Italy. Another method of recruiting patients, and this will impact in the sample, is by internet, social media, or more common media such as television, radio, and billboards. Each method has its limitation. For example, social media and web page might exclude patients that do not have access or are not familiarized with computers. On the other hand, if you advertise it on television and radio, you won't get me. For example, I'm always on YouTube and Spotify. So every different sample method has its advantages and disadvantages. Or we can do the convenience sampling, and we will apply this in our center in upcoming trials. So we have here the hospital, and we will enroll patients that go to the hospital, but we cannot say that those patients represent the whole population of the region or of Italy. This is kind of a biased sample. Only a few patients that naturally, by convenience, go to our center, and then we'll try to recruit and enroll those patients. So this is a device that will be tested here. It's called artificial diuresis 1, AD1. It is a device intended to do isolated ultrafiltration in patients with fluid overload. And then returning to the trial, which was the research question: can dapagliflozin improve outcomes in patients with heart failure with preserved and mildly reduced ejection fraction? So this is the research question. And we apply the F.I.N.E.R criteria to evaluate if this is a good research question. So F stands for feasible. Is this that we are planning to do feasible concerning expertise? Yes, this trial is funded by AstraZeneca. They have a bunch of colleagues, experts in running clinical trials. Is this affordable in time and money? Yes, I don't think money would be a problem for AstraZeneca. Is it interesting? Yes, because heart failure is a major health problem in the society, and nothing works on the top of the drugs that we already use for those patients. In the case of heart failure with preserved ejection fraction. Is this approach novel? Yes, no one has done it before to try this kind of drugs in patients with preserved ejection fraction, only with reduced. Is this ethical? Yes. And relevant, of course, to current knowledge, to clinical application, but also to future research. So this research question covers all the items in the F.I.N.E.R criterion, which makes it a good research question. And we know all of the benefits of SGLT2 inhibitors. And then recently we have this case in which the reporter asked the Queen, what is the secret for a long life? And she replied, well, I've been taking dapagliflozin for a while. In our study, the inclusion criteria main was ejection fraction above 40%, New York Heart Association class 2 to 4, patients older than 40 years old, and with high NT-proBNP. In patients with sinus rhythm above 300 picograms per ml, and in patients with atrial fibrillation above 600 picograms per ml. Exclusion criteria were patients with a glomerular filtration ratio below 25 mL per minute, patients with type 1 diabetes, reduced life expectancy, or other some etiologies of heart failure, such as cardiomyopathy or obstructive hypertrophy. Now, discussing the design. So this design is 1-to-1 ratio allocation. It means that one patient will get the intervention and another patient would get the placebo in this proportion. Sometimes this is the most used framework, but sometimes this differs. For example, recently, also from AstraZeneca, we had the trial of Evusheld, those monoclonal antibodies against COVID, against SARS-CoV-2. In that trial, the allocation was 2-1. So 2 patients received the intervention and 1 patient received placebo. Then you see here in the left part of the figure that we have the eligible sample, but we randomize a few of those eligible patients. And then this study, the follow-up would be around 2 years. You can see here in the x-axis the timeline, and we see the number of visits, like after 30 days, 4 months, and every 4 months thereafter. Now it comes to the hypothesis. And in research in general, we have, in science in general, we use these terms. HO, which stands for null hypothesis or status quo, which means that I assume that the intervention will not work. So our premise is that what we are doing, the intervention, will not change the status quo. The patients, the outcomes will remain the same. We have also the alternative hypothesis, in which we claim that the intervention changed the outcome of the patient. So if we prove that the alternative hypothesis is true, then we refute the null hypothesis. And in our interventions, we always want to refute the null hypothesis to prove that our intervention can change outcomes. This is the representation, the graphic representation called the forest plot. And we have this line in the point of 1. And if the results are at the right side of this line, we get a benefit of placebo. This is the mean result, and this 2 bars there, they are the 95% confidence interval. On the left side, if our result is here on the left side, then with the confidence interval of 95%, we can say that the intervention improves outcomes when compared to placebo. So here is represented that the null hypothesis, the status quo, was rejected if our result is in the white circle. If our result crosses the line of 1, then we can say that Dapa is not superior to placebo. So we cannot refute or reject the null hypothesis. The null hypothesis is true in this case. The drug does not change outcomes. Or we could have the result that placebo is better than the drug. So we can also conclude that this drug is harmful to patients. And then we will refute the null hypothesis, because the null hypothesis says that both intervention and placebo are equal. In this case, we had the opposite. So we had placebo better than intervention. So here are our 3 possibilities. On the left, Dapa is superior, so the null hypothesis rejected. Here, Dapa is not superior, so the null hypothesis is accepted. And here on the top, Dapa is inferior to placebo. The null hypothesis is also rejected. Another way to represent these results is by displaying the distribution of results in this bell-shaped curves, a Gaussian distribution. So this curve more in the right represents the results in percentual of the events for placebo group, and this one in the left for SGLT2. And in this case, we can see that these results are quite similar. So in this case, it says that the null hypothesis is true. So we cannot reject that hypothesis. And when we go to this picture here, we see that the interposition between the results here on the right in the placebo versus there in the left for SGLT2, they do not cross. Only less than 5% of these results have this interface. So in this case, we can say that we refute the null hypothesis, and these are the true results of the trial that I will demonstrate afterward. So the negative event occurred in 16% of patients in SGLT2 group versus 19% in the placebo group. So if the interposition here in the results is less than 0.05 or 5%, we claim that the null hypothesis is rejected. Now, this is not specifically the design of this trial, but I would like to cover the issue of non-inferiority. So we will illustrate that with the trial of the AD1 trial. Well, this is a simple trial. It's the first in human use of the small device that is intended to apply only isolated ultrafiltration. So in this trial, 15 patients will be enrolled, and they will carry out either a session with AD1 or with a traditional machine, in this case, Prismax. And then it's a crossover, and then the ones that did the first treatment with AD1 will do with Prismax. The expected efficacy outcomes would be the amount of ultrafiltration concerning the prescribed dose and the delivered dose. And in this case, a 10% difference would be acceptable for this device. In this case, a non-inferiority design is advisable, because in the non-inferiority trial, we don't want to say that the intervention, that AD1, is better than the standard of care. If AD1 is equal or even worse, but in a margin that is not clinically significant, this is a good intervention because it's a smaller, it's cheaper, you can perform it in the ward, so there are other benefits that will compensate inferiority in efficacy. To represent this concept of non-inferiority, let's return to the same forest plot. So here we have the line of 1, and if the results are here, it means that Prismax is better, this point. If the results cross the bar, AD1 would be better. As I said, I probably know that AD1 is worse, is not so precise as Prismax. But if these results are an acceptable worse, then it's okay because of the other advantages. So I mentioned this as the sweet spot because we traced an arbitrary margin. So we choose that margin of 10%. So if the difference between the prescribed dose, let's say 1,000 mL of ultrafiltration, is less in this case than 100, so less than 10%, this would be acceptable. This would not be clinically significant if your ultrafiltration 1,000 mL or 1,050 mL. So we created this margin. It's an arbitrary margin, which was 10%. We justified this margin because we think it's not clinically significant. And if we have the results of AD1 here, excellent. AD1 is worse. I know that from the beginning, but it's an acceptable worse. So this is the concept of a non-inferiority. And it's important to mention this because when you apply this design, the title of the article should be, the word should be there in the title, a non-inferiority title. Because when this is not in the title, the reader can assume that this was a superiority trial. And also the reader can assume if one says non-inferior means equal. It's not the same thing. Equal is one thing. Non-inferior means that it's worse, but an acceptable worse. We can also mention here the case of antibiotics. Imagine that you have antibiotic A, which is intravenous, and the treatment time for cure is, let's say, 7 days, right? And then you have the older antibiotic which is oral route, and the treatment takes 9 days. So the first antibiotic in theory is better. But let's say that this one, the pill, allows the patient to be discharged, has less side effects. It's an easier route of administration, venous versus oral. So even if this antibiotic has a higher efficacy, in the overall, this one has advantages. So if this this antibiotic is inferior to this one, but in an acceptable manner, and we tested it as non-inferior, it's okay. It justifies that you change for one treatment to the other. And this has been doing here in Vicenza in the Metropolis trial comparing tolvaptan with metformin in patients with autosomal dominant polycystic kidney disease. So let's say, for example, if metformin proves to be a bit worse, let's say in 5 years, there is a difference in the GFR of 5 mL, we can claim that tolvaptan is better, but this 5 mL, does it make a big difference for a drug like metformin, which is cheaper, is tolerable, has less side effects than tolvaptan? So this is the way to interpret the condition of non-inferiority. And then we come to the topics of objective versus endpoint. So in the DELIVER trial, the objective is to prove that dapagliflozin is superior to placebo in reducing the cardiovascular outcomes. So cardiovascular death, heart failure events, hospitalization or urgent emergency visit, and in those patients, that sample that we already mentioned. This is the primary objective. The endpoint or outcome is how I will measure my objective. There is a difference between our primary objective and primary outcome. Primary objective is it's the idea, is the concept that I want to prove, whereas the outcome is how I will measure that to prove or refute my first claim. So that is the objective, to show that the drug is better than placebo. And to calculate the sample size, we base that on the primary outcome. So you know that all studies, they have primary outcomes and many secondary outcomes. The importance of the primary outcome is that the sample size will be calculated for that. So when we have the results of the trial, this is confirmatory for the primary outcome. For the secondary outcomes, we would need a different sample size. And then we claim that the results for the secondary endpoints or outcomes are exploratory, not conclusive, let's put in these terms. So our primary outcome, it was a composite primary outcome in the DELIVER trial. So cardiovascular death, hospitalization for heart failure, or emergency visit for heart failure. Concerning secondary outcomes, for example, the patient reported outcomes, which is a subjective metrics, and for example, reduction in all-cause mortality. Remember again, the sample size was not calculated for these outcomes, but rather for these other outcomes. And when it comes to interpret trials, this acronym easily put all the ideas in few words, is the PICOT. In that acronym, P stands for population, I for intervention, C control, O outcome, and time follow-up. In this case, our population are those patients with heart failure. The intervention is the drug itself versus standard of care with placebo. So this is the control group, the standard of care. The outcome are those concerning heart failure, visit to emergency room, and then time of follow-up. Time is really important, because if the follow-up of our study, which is around 24 months, was 2 months, I would say that the drug doesn't work. But this is a wrong conclusion, because it didn't follow the patient for as much time as it is needed for the drug to demonstrate its effects. So whenever you're reading a trial, an article, put all this information in your mind so that it will facilitate the digestion, the deciphering of that article. So population, intervention, control, outcome, and follow-up. And then comes an interesting thing, which is randomization. So the role of randomization is to balance groups, is to give you the certainty that all the characteristics in one group are equivalent to the characteristics in the other group. So the best way to balance two groups is through randomization. And we have different methods of randomization. One of the most applied is blocked randomization. How was then blocked randomization? In this case, we could give Dapa or placebo. So imagine that Dapa is represented by this black man and placebo by the white man. And if you're throwing a coin, you can have this distribution: placebo, Dapa, 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 placebo, Dapa, Dapa, placebo, 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 and Dapa. Imagine that we have two centers, the center in Vicenza and the center in Brasília. My goal is to have the same number of patients receiving placebo and intervention in Vicenza and in Brasília. But let's say that we only have 4 patients in each center. And this situation could happen that the 4 patients in Brasília would get placebo and the 4 patients in Vicenza would get the intervention. So when we are randomizing, then we create blocks. In this case, blocks of 4, in which in those blocks of 4 patients, 2 would get the intervention and 2 would get the placebo. So here are some examples. One block can be Dapa, Dapa, placebo, placebo. Another block, Dapa, placebo, Dapa, placebo. Another block, the other way around. And so we have many different possibilities. And while the computer system is making the randomization process, it's making in blocks, so that we don't see this situation in which, in theory, there is the possibility of many patients receiving only one treatment and then the other way around. So in all those trials, there is this strategy of blocked randomization, so that in the centers, when we're talking about multi-center trial, I can reassure that the distribution between intervention and standard of care will be similar. Another point in randomization is the stratified randomization. What does it mean? So strata, we can interpret strata as levels, okay? In this case, for example, we can make 3 strata. So one of the strata would be patients with GFR above 60 miles per minute. The second strata would be patients between 30 and 59, and the third strata between 25 and 29. I choose previously that in our sample, we want to have 10% of the patients with this GFR in the stratum 1, which means that if during the trial we reach this number of 10%, I will stop to include patients with a GFR above 60. And then I want 70% of patients with between 30 and 59 and 20% between 25 and 29. Because by randomness, I could only include patients with a low GFR, like let's say 30%, but I cannot claim that those patients represent a larger proportion of patients. So before starting the trial, I can do this stratification. Another example, I can stratify it by ages. So I can select previously that 45% of my patients are older than 70 years old. Otherwise, if I don't do it, there is the risk that I include initially, let's say 60% of patients in the age range from 40 to 49, and then my results would not represent the impact of the intervention in older adults, such as ones older than 70 years old. So This is also commonly applied in trials to have strata so that you can be sure that in the recruitment process, the percentage of patients in different age groups or different GFRs or different NT-proBNP levels or different ejection fraction are allocated so that you have then generalizability of the results of the trial. Now, sample size calculation, and I will explain these two concepts, alpha and beta. Alpha means the acceptable false positive results. So we came all together, the community of statisticians, and we decided that 5% of false positives are acceptable. So, for example, this physician is telling to this patient that you are pregnant. We know this is not true. This is not possible. In this case, for pregnancy, this is a false positive result. And a synonym for that is type 1 error. So if you say to this old man that he's pregnant, this is a false positive result. We accept that the risk of our trial to have a false positive conclusion is 5%. Okay, so this is the meaning of 0.05. 0.05. This means that we accepted a 5% probability of our trial finding a false positive result. Then we have beta. Beta is related to the risk of having a false negative result, which means that the intervention improves outcomes, but our trial could not demonstrate that. So we had a false negative result. So for example, in this case, this woman is pregnant and the physician says, oh, you're not pregnant. So this is a false negative result, a negative result for pregnancy, which is false. In general, the percentage accepted is 20% for false negatives. And we also mention this as study power. 1 minus beta is 80%. So this is the study power. Beta then is 20%. The less beta, the higher the study power. And someone can ask me, so why alpha we put it at 5% and beta at 20%? Because it's better to accept something is not, will not change the clinical practice. So we have a 5% chance of wrongly changing the clinical practice and a 20% chance of having something that would improve the outcomes, but we didn't see it. I will explain that in next slides. Concerning the liver trial, so alpha was 0.05. So this is the acceptable percentage probability of a false positive result, okay? And beta was small, only 7%. Usually in trials, they use 20%. And then the study power, 1 minus beta, was 93%. So we have a chance that the results of our trial, it was a 7% chance that these results are a false negative. In other words, the drug works, but we could not prove it. And then we said it doesn't work, it doesn't reject the null hypothesis, but we were wrong. So this is a false negative. And then someone could ask, why not reduce alpha and then also reduce beta, so we could be more certain that we would have fewer positive results, false positive, and fewer false negative. This is the ideal. However, the less is alpha and the less is beta, you have an increment in your sample size. So this makes in practical sample size, let's say 20,000, 40,000 patients. So we have these limitations. And taking back to COVID, imagine if in the trials with hydroxychloroquine, we had a false positive result. So we had a chance in 20 of proving that hydroxychloroquine works, and we will be prescribing till this day hydroxychloroquine to treat COVID. On the other way around, imagine if we had a false negative result with the vaccine. So, for example, if our beta was 20%, we had a chance of 20% of the results being a false negative, even if the vaccine works. So imagine the situation in which we had a type 2 error, we would conclude that the vaccine does not work, and we would not give the vaccine to anyone. So these issues are really important. In the end, the trial, the sample size was calculated based on alpha and beta, and it was 6,100 patients. And then the results. So this is a Kaplan-Meier curve. In the x-axis, we have days since randomization, mean follow-up 2.3 years, and then the cumulative incidence of those negative outcomes. And we can see that the percentage of events in dapagliflozin was lower than in placebo. And we have the p of 0.001. What does it mean? This p means that the chance with these numbers of having a false positive result are less than 1.0%. So one thing is alpha. Alpha was what we decided to accept as the rate of false positive. It was 5%. But the results of this trial are way below 5%, 0.1%. But still, there is a chance that this is a false positive result. So we are saying that Dapa is better, but this could be a false positive. I could say to this older man that he's pregnant, but the chance of that happening now with the results is 0.1%. Then we have the number needed to treat, which means the number of patients getting the drug that I need to enroll so that I will reduce one of those negative, the composite negative events. In this case, it was 32. So every 32 patients taking dapagliflozin, I have reduced one of those outcomes. So we need to treat 32 patients to benefit one patient, which is good for this kind of intervention. And then the results, finally. So for all patients, we got this result, the hazard ratio of 0.82 and the confidence interval from 7.73 to 0.92. So we rejected the null hypothesis. Dapa is superior to placebo. The number of events here was lower than in placebo. And we can also perform subgroup analysis. But then the Queen said this, Charles, be careful with your conclusions. So we need to think calmly before the conclusions. For example, in this study, these results are real. In patients with a GFR below 60 mL per minute, Dapa was superior to placebo. So in this subgroup analysis, and we are fine with that. However, in patients with GFR above 60, the results demonstrate that Dapa is not superior. So we didn't reject the null hypothesis. Can we claim that Dapa doesn't work in this group of patients? We can't, because the sample size was calculated for 6,100 patients. These patients with GFR above 60 are not 6,000. So this is only an exploratory result, not confirmatory. And we can also analyze that it crossed the line of 1. It just reached the line of 1. So likely, see what's interesting, likely this is a false negative result. I mean that likely this result came in that 7% chance of you getting a false negative, like the drug works, but I could not detect that in my trial. Concerning, for example, patients with ejection fraction above 60%, Dapa was superior, but in patients with ejection fraction below 49%, Dapa was not superior. But again, it's we cannot conclude based on results of subgroup analysis. And then bringing it to our reality of blood purification, do you remember the Euphrates trial in which they compared in patients with gram-negative infection, hemoadsorption with toramycin to remove endotoxins versus sham therapy? And the trial, the results were neutral. There was no difference. So the intervention could not reject the null hypothesis. However, in a subgroup of patients which had endotoxin activity between 0.6 to 0.9, in those patients, the intervention was positive. First, this is a subgroup analysis, so it's not confirmatory, it's exploratory. This is one point. And second, this was a post hoc analysis. What's the difference? Because this analysis in the liver trial, before the trial started, they were pre-specified, which means that the researchers said, we will evaluate this, this, and that. Whereas in the post hoc analysis, after the results are published, the researchers do different analysis, but then one can claim that you can manipulate results to see a positive result. For example, I could test patients with 0.4 to 0.6, or I could test only women. I could test women and old men. So you can try to do different combinations, and you find a positive result that might be just a false positive. So this is the criticism, this is the limitation of a post hoc analysis. It's better if you pre-specified all the analysis before the trial starts. So I thank you for your attention, and I'm open to discuss that. These are my contacts, email and Twitter. See you later.